अब इसको प्रेस करना है। हाँ, शुरू करें
जी मैडम, स्टार्ट करें मैडम।
चलो, अस्सलाम वालेकुम। आई एम Dr. Sara Kazi and I will be taking management of subfertility. So basically, this slide says assisted reproduction, but management of infertility means many other things other than assisted reproduction. First of all, what are the learning objectives of today's lecture? Once we have done with the lecture, then at the end of the lecture, you should be able to define, in fact, you should be able to define what is infertility, what are the types of infertility, what are the management options, and then of course, assisted reproduction and the available methods, what are the indications, and what are the complications associated with assisted reproduction. Sorry. Okay. What do we mean by assisted reproduction? Whenever the couple is not able to conceive on its own, then you assist reproduction, in which you take the ovum, you take the sperm, you mix them outside. Once they are at a particular stage, you transfer the embryo inside the uterus. So before we go on to the available methods, I would like to define subfertility to you all. Well, when a couple has been trying to conceive and has had unprotected intercourse for at least 1 year and still they are unable to conceive, then you say it is infertility, or a better terminology is subfertility. There are two types of subfertility. One is primary and the other is secondary subfertility. Primary subfertility, when woman has not conceived even once, whatever the outcome, whether it was miscarriage, ectopic, term, preterm, but she has never ever conceived. She has never been pregnant. That is primary subfertility. Secondary subfertility is when she has conceived once, whether it was miscarriage, ectopic, term pregnancy, live baby, dead, NND, whatever, but she did get pregnant at least once or twice. And later on, she was unable to conceive for at least 6 months have passed while she has been trying, but still she is not conceiving. Then you can say that it is secondary infertility. So once you have identified the type of infertility, you must know what kind of problems will have better prognosis and what are the things which will have poor prognosis. So there are three main things. The most important one is age of the female. The older the woman, the difficult it is for her to conceive. Then, what is the duration of infertility? The longer the duration of infertility, the more difficult it will become for her to conceive. Third, whether it is primary or secondary infertility. It is usually difficult in primary infertility, but secondary infertility results are better. So what are the management options? Of course, if we do define that, well, this couple is unable to conceive on its own, then we help it. How do we help? We can either do ovulation induction if it has been identified that ovulation is the problem. If ovulation induction fails, then we come to assisted techniques. Simplest being IUI, which is intrauterine insemination, then IVF, in vitro fertilization, then gram intrafallopian transfer, zygote intrafallopian transfer, which is zipped, pronuclear stage transfer, and tubal embryo stage transfer. Usually the common procedures which are being carried out is IUI, IVF, and GIFT or ICSI, intracytoplasmic sperm injection. what are the indications where you need assisted reproduction? If you identify that there is an ovulation, how would you identify there is an ovulation? Either the cycles are irregular, prolonged, delayed periods. Usually that is an indication that ovulation is not taking place. If ovulation is taking place, then the cycles are usually very regular. So if there is an ovulation, and how can you confirm? If you do in a regular menstrual cycle, if you do a day 21 progesterone, if it is less than 25 or 20, then it shows that there is no ovulation because the progesterone levels are low. But that is only when there is regular cycle. If it is irregular, then from day 21, you need to do repeated progesterone levels, maybe every alternate day, till you find when and where did she ovulate. So an ovulation. Then tubal blockage. Tubal blockage again is a condition in which you can't do ovulation induction. In fact, you would need to do either IVF or HC or some kind of an assisted reproductive technique. And tubal blockage can be due to multiple reasons, but the main factors which are important in tubal blockage are a pelvic inflammatory disease, endometriosis, and sometimes somebody who has had a tubal ligation already. So these are the things which can cause tubal blockage. Adhesions due to any reason, due to surgery, due to endometriosis, due to infection, due to burst appendix, it could be anything. Cervical factors. Cervical hostility where the patient has antibodies against the sperms, or there is some other antigen-antibody reaction which does not let the sperm penetrate, then in that case, you need to bypass that barrier. And for that, again, IUF, IVF, and GIFT are the procedure of choice. So, again, as we said that there are different causes of infertility. So, there can be male infertility as well. Now, there can be azoospermia. If there is azoospermia, then these procedures can also not be done. But if there is severe oligospermia, then there is a possibility that these procedures may be helpful. And you need to know the causes of male infertility. They can be viral infection like mumps in the childhood, undescended testes, vasectomy in some people, then orchiditis, and many other factors, excessive heat, which affects the sperm quality. So all these reasons, these factors can lead to oligospermia and problems with the semen. In that case, again, IUI, IVF, and GIFT are the choices. Then we come to unexplained infertility. You investigate the male. Always remember that when you are dealing with infertility, it's not one person. There are two people who you are dealing with, and you need to investigate two. And you need to take a very thorough history of the couple, not just the woman. So history becomes very important because you would find many things in history which would give you an indication that what could be the most probable cause. Having said that, once you've taken history, examination, and all investigations, and you don't find a cause, and still they are unable to conceive, then you label such couples as having unexplained infertility, in which you have found no particular reason or etiology of their infertility. Okay. So the first step is, how do we do inductions, ovulation induction? Now, usually, if it is not for assisted reproduction, there's simple ovulation induction methods. You can use Clomid, which is clomiphene citrate. It is an anti-estrogen. Or nowadays, most of the people are using letrozole. The good thing about letrozole is that it is anti-estrogen, but does not have anti-estrogen properties on the endometrium, whereas clomiphene citrate has anti-estrogen properties on the endometrium as well, and which leads to thinning of the endometrium. So letrozole gives a better response of endometrium as compared to clomiphene citrate. and you do need a good endometrium at least 7 to 8 millimeters in thickness before embedding can take place. So, two regimes, one with clomiphene citrate. You can start with the lowest possible dose, which is 50 milligrams, starting from the second day, giving it for 5 days, which brings us to 7 days. And then you do an ultrasound on the 12th day and see and check the size of the follicle. If the follicle size is 18 to 20 millimeters, that means it's a ripe Graafian follicle, and you can trigger an ovulation by injection IVFC, which is human chorionic gonadotropin, 5,000 to 10,000 international units. And then you ask the couple after injection that after 36 hours, they should have intercourse every alternate day for at least 4 to 5 days. If this does not work, you should at least try 3 to 6 cycles. And if you think that ovulation is not taking place or the Graafian follicle is not maturing, then you can increase the dose to 50 milligram BD or 50 milligram TDS. So 150 milligrams, you can take it up to 150 milligrams. Similarly, if somebody does not respond on Clomid, then what you can do is you can give letrozole. It comes in many names, Lesra, etc. It's 2.5 milligrams. You start from the 3rd day of the menstrual cycle, give it for 5 days, again a BD dose, then ultrasound on the 12th day to see and check the Graafian follicle size, which should be again 18 to 20 millimeter. The endometrial thickness should be about 7 to 8 millimeter. You can give a trigger at that point for ovulation induction, and that would be with human chorionic gonadotropin, 5,000 to 10,000 international units given intramuscularly. Again, after 36 hours, advise the couple to have intercourse every alternate day for the following week. If this also fails, we can use injectables, FSH-LH injectables, along with clomiphene citrate or letrozole, and then we need to track the follicles. If, for example, you're giving oral ovulation induction drugs like clomiphene or letrozole, then from the 8th and 9th, 10th, different people have different regimes. You can give 7th, 8th day injectables, you can give every alternate day injectables, but then you need to track the size of the follicle. How big is the follicle? If the follicle is still not mature, you can give another injection. Then again, do an ultrasound and track. Once you attain the desirable size of the follicle, which is 18 to 20 millimeter, then again, the same procedure, you give ovulation induction and you advise accordingly. If this procedure fails and you have tried 6 cycles, then you go, the next step is to go for IUI. What is IUI? Intrauterine insemination. In this, what you do is you prepare the semen and you pick up the most viable and healthy sperms and you fill them in an injection kind of a thing, and you give either ovulation induction to the woman, or if she's ovulating properly and normally, then you need not give her ovulation induction. You just need to see when is her follicle, the Graafian follicle, is mature enough. Once it is mature enough, you give the human chorionic gonadotropin trigger, and at that time, you inject the prepared semen. This is known as IUI. And if she misses her periods, then you do a beta HCG to confirm pregnancy. If this also fails, then how do you monitor the growth? By ultrasound and by estradiol levels. In the follicular phase, the estradiol levels are high usually. So that would also give you an indication that the follicle is maturing. And again, 18 to 20 millimeter size of Graafian follicle. These are the injections. You can use human chorionic gonadotropin for ovulation. As I've already told you, timing would be a mature follicle, 18 to 20 millimeter, and then you can give luteal support. You can get progesterone in the luteal phase for at least 7 to 10 days, and then stop and see. If she menstruates, she never conceived. If she does not, then she's pregnant. Then you do a beta HCG. What are complications of ovulation? Mainly, you can end up with hyperstimulation, which can be mild, moderate, and severe. And in severe hyperstimulation, it is life-threatening and one needs ICU care. So you have to be very vigilant towards the signs and symptoms of ovarian hyperstimulation. And if there are signs of hyperstimulation, that the patient is unwell, there is tenderness, pain, ultrasound shows big cysts, then you need to abandon the procedure and stop immediately. Then ovulation induction leads to multiple pregnancies, and multiple pregnancy again is a high-risk pregnancy because all complications of pregnancy like hypertension, diabetes, preterm labor, polyhydramnias, they're all associated with multiple pregnancy. So you need to be careful. And again, miscarriages, of course, is a known complication. How do we do IVF? What is the procedure? First, you again do ovulation, superovulation. You first downregulate the ovaries and then you stimulate the ovaries. Once the ovaries have a mature follicle, then under GA, under ultrasound guidance, you retrieve the oocytes. You retrieve the oocytes. Meanwhile, the sperms have already been prepared. Then you incubate the oocyte and the sperm and wait. This incubation, or once you retrieve, up till retrieval is the gynecologist. Then you retrieve the oocyte and give it to the embryologist. The embryologist will incubate both the oocyte and the sperm. And once it is fertilized and it has reached at least 8-cell stage, at that point in time, you can transfer the embryo into the uterine cavity. Previously, they used to say that at least 2 to 3 embryos should be transferred, but that led to a lot of problems of multiple pregnancy events. So now the recommendation is to transfer only 1, and you can freeze the rest so that if it is a healthy conception, then you can use them at a later stage if this particular procedure at this particular point in time has failed. Once embryo transfer has been done, then luteal support is given by progesterone, either tablets or injectables, but they need progesterone support. What are the complications of IVF? The main problem, we see that the success rate is not more than 20 to 30%. And that also in expert hands, good centers, all sterilization, protocols being followed. In those centers, you get about 20 to 25, 30% outcome from in vitro fertilization. Failure is very, very high, 80 to 90%, and it's a very, very expensive procedure anywhere in the world. So one needs to be very careful who you are offering it to, and they need to know what are the chances of good outcome and what are the chances of failure, so that such an expensive procedure does not lead to too much financial burden and disappointment and psychological effects, which of course these people do have. Miscarriages, again, as in normal pregnancies, a little more in IVF pregnancies. Multiple pregnancies, as I already mentioned, and congenital malformations. Again, I would say congenital malformations nowadays, because there is a method of testing for genetic disorders before you implant. Pre-implantation genital studies can be done, and at least chromosomal abnormalities can be avoided. But congenital malformations, structural malformations, again, can happen with IVF, as they do happen with normal pregnancies as well. Premature labor, anxiety, any medical complication develop, or if there is excessive amniotic fluid due to any reason, but it has been seen that premature labor is more common in IVF pregnancies as compared to normal and complicated pregnancies. Again, for gift fertilization at a natural site, you do the same cycle treatment, same sperm preparation, same oocyte recovery, and then catheterization through fibrillar end of the fallopian tube and loading of oocyte and sperm in the ampullary part of the fallopian tube, followed by luteal support. The success rate of gift is hardly 25 to 30%. Great risk of abortion and ectopic pregnancy because you are directly injecting it into the fallopian tube. So it may flourish there and may not move on further. So the risk of ectopic pregnancy is much more in gift than in IVF. And of course, multiple pregnancy depending upon the number of zygotes or marula you have transferred. Okay, so there can be donation, sperm donation, not ethically allowed in our country, in our religion. There can be ovum donation, there can be embryo donation, you can freeze the embryos and donate, and of course, you can thaw the frozen embryos and donate, but all these things are more of the Western countries and are not legally allowed in our country due to religious restraints and of course a lot of litigation is involved in these procedures. IUI, as I have explained before, it can be done in natural cycle or it can be done super ovulation. Then you check for follicle maturity, give her HCG trigger, and then need to tell them regarding the proper timing when this insemination can be done. And that would be 36 hours after the HCG trigger. So that is about IUI. So I'm ready to take any questions because this was a very small topic. Actually, it was just assisted reproduction. I tried to elaborate it with giving you the basic definition and everything. So if you have any questions, I'm happy to answer. ये कैसे participants के पास share करूँ मैं ये? Hello?
जी मैडम।
बेटा ये मुझसे क्वेश्चनिंग की वो शेयर करवाएं इनसे अगर कोई क्वेश्चन कर रहा है तो हाउ डू आई डू दैट?
हाँ मैडम चैट बॉक्स खुला हुआ है उस पे आएगा। देखिए ऊपर मोड का ऑप्शन आ रहा है, देखिए आप ऊपर 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 की तरफ स्क्रीन पे जाएंगे ना, मोड लिखा हुआ आएगा।
स्टॉप वीडियो सिक्योरिटी पार्टिसिपेंट्स
मोड लिखा हुआ है। मोड
कहाँ जाऊं? मोड पे?
हाँ मोड को क्लिक करें, उस पे चैट बॉक्स आएगा।
भाई चैट बॉक्स नजर आ रहा है कहीं? Okay. Okay. Can you repeat the process of IVF? IVF, beta, what you need to do is you need to do ovulation induction. For example, you are giving Clomid for first 5 days, then you give injectables. There is two ways. Then you can down regulate the ovaries and do it, or you can directly do ovulation. Then you see and track the follicles. Once the follicle is mature, about 18 to 20 centimeters, under general anesthesia, under ultrasound guidance, you take out or you retrieve the oocyte, give it to the embryologist. Meanwhile, the sperms have been prepared. So the healthy sperms and this retrieved oocyte that is fertilized outside, once it is at an 8 cell stage, then it is transferred into the uterine cavity. So, can you repeat timings? What timings, beta? What are you asking regarding timings? Okay, HCG trigger. Once you've given ovulation induction and you are tracking the follicles by ultrasound, if the one follicle, even if one or two follicles, you find that they are 18 to 20 millimeters in diameter, And the endometrial thickness is about 8 millimeters, at least more than 6 to 7 millimeters. Then you give a trigger of 8 cg, 10,000 international units intramuscular, and wait for 36 hours, and then tell the couple to have intercourse for the following 1 week. In case of pathology in mother's uterus, what are the possible, what kind of pathology? People do conceive with fibroids as well, so I don't know what kind of pathology are you talking about. If there is a huge myoma which is hampering implantation, then of course you need to do a myomectomy first, and then later on, once the uterus is healed, then you can go for any kind of artificial reproductive technique or ovulation induction. Any other question? Chale ji, I think we are done.